Yeah, so very good morning, and at the outset, I'd like to thank Sanjay for this opportunity to present our work here. I bring greetings from my institution, my former institution, Modern Azad Medical College, from where I accepted the invitation, and the current one from where I moved out to a private setup after serving the government for 25 years. So we have seen over the last 2 days here that everyone has been operating on patients based on their experience, choices based on the evidence and literature, their personal preferences which they have gained over time, presence of comorbidities, and then we tend to work on those indications and keep doing the surgeries that we have been trained with or we have been performing. But I still feel that there has been a lack of anatomical criteria to choose between various operations that we do, which could be more objective in nature. We know that bypass achieved its status as a gold standard operation, and then very quickly sleeve gastrectomy came in to challenge and has become actually one of the more commonly performed procedures in the whole world, and in many countries the only or the majority procedure performed. And so when we started our work, we started in the same sequence, and we took on to the sleeve gastrectomy, and you would agree that many times when we do the sleeve, we find that it's what a very slender or a very small sleeve we bring out, and in other cases we find that we have a very large sleeve, and you think that yes, this would have really been the right indication. So considering from that thought process, we started this research 13 years back, and we took patients and measured their pre-operative CT volume using multi-detector CT, pre-operative, and then various intervals post-operative. And very interestingly, we found that early post-operative weight loss, which was in part of that study at 3 months, correlated with the volume of the excised stomach and not with the residual stomach. That means that larger stomachs would actually benefit from doing a sleeve. And this we published in Surgical Endoscopy in 2014. This was one of the first articles which was in the literature to show that early post-operative weight loss correlated with the excised volume and not with the residual volume. And there was a tendency to do narrow and tighter sleeves, and we all found that we were having problems in that, and there was no need to do that if we were to choose stomachs which were preoperatively bigger. Preoperative CT volumetry uses effervescent carbon dioxide produced by sodium bicarbonate, and you distend the stomach, you take three-dimensional CT pictures, this is how it looks. And we also correlated the excised stomach by doing a saline distension with up to the elasticity level of the muscle using the manometry probe so that you don't over-distend the stomach. And we found that the CT volume post-operatively minus the pre-operative value were correlated with the actual physical excised volume. So we found that CT volumetry is a good method to study CT volumes. In the subsequent study, we continued to enroll patients and studied them at 3 months, 12 months, and then did a long-term study of the patient that we had done at 5 years. And we wanted to see what happens to the excess weight loss and absolute weight loss at these points of time. So we had first cohort of 15 patients which were operated between 12 to 14. We had the second cohort of 13 patients which were operated between 17 and 18. So we had a 28 patient cohort. So the first cohort we had the data for 28 patients for 3 months, 13 patients for 1 year, and 9 patients we were able to get at 5-year follow-up. This is how the residual CT volume looks. So you do a post-operative CT volume at those points of time at the times indicated, and that is how the CT picture of the residual stomach looked. So in this particular graph, we could find out that the CT stomach volume, correlating the CT stomach volume, the excess weight loss and absolute weight loss, that despite a steady rise that you see in the stomach volume, the weight loss continued the same way. So that was the study at 3 months, that was at 12 months, and that was at 5 years. despite the rise in the residual stomach volume, and we all know that stomach volumes do increase in size with time, the patients still continue to maintain the weight loss. So what was the reason for that? So we studied the second point, which was the resected stomach volume, which now we had with the help of CT volumetry, and again we found that the same correlation showed at all the 3 time points that the resected stomach volume correlated with the weight loss both in early, short term and long term at 5 years old. Despite the you see the progressive increase in the resected stomach volume, so that's the higher stomach volume, the larger stomach that we remove, they correlated with the weight loss. They continue to have that weight loss. So weight loss is proportionate to the larger stomachs that have been operated with. And this was the 9-patient study, which was the 5-year, this is the long-term study, which again showed that the weight loss is proportionate to the resected volume, and if you choose the right larger stomachs, perhaps we would have chosen the right operation for the patient. Then, very interestingly, we studied these 28 patients in terms of their preoperative volumes, and we found that they fall into 2 cohorts. One cohort of patients which are less than 1000 ml in volume, and the other cohort which is more than 1200 volume, and the outliers in between are very, very few. So 900 was kind of the average in one peak and 1250 in the other peak. So could we use this as a method? So we then studied these operated patients, and we found that there was a significant difference in the patients who had a larger stomach volume, more than 1200 ml, and the smaller ones. That was significant difference between the two in terms of their absolute and total weight loss. So that makes sense that if we were to use this criteria to choose our operation, perhaps we would have found an objective way to add an indication to our study. So we now started doing the current research, and we have operated 22 patients, 14 sleeves and 8 MGBs on the basis of this criteria, and that in the current study, this was the graph that we showed, these patients fall into these. So the 14 people were in the group more than 1200 ml, 8 people in the group which were less than 1000 ml. These people got the sleeves, these people got the bypass. We do the one anastomosis bypass. The outliers are only 3, and you could do the current modality of your judgment to decide the surgery that you want to do based on the indication that we use currently. And so the decision-making process became pretty straightforward for us. For people who have got smaller volume stomachs, took them to one anastomosis. For larger stomachs, took them to sleeve gastrectomy, and we find that the weight loss is very successful in both the groups. We have used a method to choose the type of operation that they get, and this is obviously very initial study, and we are just collating more data to make it into a publication. So to conclude, ladies and gentlemen, Chairman Sir, we feel that gastric sleeve volume definitely continues to increase post LSG even up to 5 years. Absolute weight loss, excess weight loss and the BMI correlate to the amount of the excised stomach volume and not with the residual sleeve volume. Larger preoperative stomachs would seem to show long-term benefit from sleeve gastrectomies. These are very small volume studies which I could do in a teaching institution as part of minimal access surgery, head to foot we do bariatrics, only limited numbers, so I could not get larger numbers, but high-powered studies would be needed to further substantiate the cutoff points. And based on the current data, we feel that more than 1200 ml from the data that we have are suitable for sleeves, less than 1000 ml for bypass, and we would possibly need more national and international collaborative studies to get larger volumes for and more statistical data. We bring greetings from my current team, and thank you for this opportunity to present our data.